Hello, in this episode we'll discuss cases related to approaching thyroid nodule. Our index case is a patient who has an incidental finding of thyroid nodule either on physical exam or some imaging studies. What's the very next step? Evaluation of TSH and neck ultrasound. True or false? If a patient with incidental finding of a thyroid nodule does not have symptoms of hyperthyroidism on clinical assessment, next step is fine needle aspiration. That's false. We need to first order TSH and neck ultrasound. What defines a thyroid nodule as suspicious or high risk based on initial TSH or ultrasound assessment? If a thyroid nodule has TSH that's normal or high, in other words, indication that it's not a functional nodule that has suppressed TSH, this is one high risk or suspicious criteria. Then there are ultrasound criteria of suspicious nodule. They include presence of microcalcification, markedly hypoecho nodule, nodule with irregular margins or architecture, evidence of abnormal vascularity in the nodule, or a nodule that has a height greater than width. All of these are ultrasound features of suspicious nodule. What findings in history and physical makes a thyroid nodule suspicious? Past history of head and neck radiation, family history of thyroid cancer, family history of men 2A or B, age of the patient younger than 14 or older than 70 years, male gender, growing nodule, firm, hard, fixed, nodule with cervical lymphadenopathy, or findings compatible with surrounding tissue invasions such as dysphagia, dysphonia, or even dyspnea. Finally, remember, any thyroid nodule larger than 1 centimeter in diameter is considered suspicious or high risk. Let's continue our index case. Our index case probability 1 is a patient with thyroid nodule that has any single one of the high risk or suspicious features. What is the next step? The next step is ultrasound guided FNA. If a patient does not have any findings compatible with suspicious thyroid nodule, what is the next step in the workup? If TSH is low and no clinical or ultrasound findings of high-risk nodule is present, next step in the workup is radioactive iodine scan with I-123. Continuing our case, if the patient without any suspicious features undergoes radioactive iodine scan and the scan reports hyperfunctioning nodule, what is the next step? Remember, it's possible to have low TSH and as a result, the iodine scan also report hyperfunctioning or hot nodule. In this case, the management is the management for hyperthyroidism. Pay attention to the fact that the rationale here is presence of thyroid nodule with just low TSH does not mean that the patient can forego further workup. Workup of thyroid nodule is not ended with just TSH assessment. We need to have radioactive iodine uptake confirmation that it's a hot nodule. Why is it so? Because it's possible to have low TSH in a patient with thyroid nodule whose results of radioactive iodine reported as non-functioning or cold nodule. What's the next step in this case? This patient would be treated similar to a high risk or suspicious nodule with ultrasound guided FNA. Now this is the final but perhaps the most challenging part of the approach. What are the 4 possible outcomes from fine needle aspiration of a thyroid nodule? It's either reported as benign or reported as non-diagnostic, or it's reported as follicular cytology, or it's reported as malignant, suspicious cytology, or Hürthle cells. Please be careful not to mistake suspicious cytology with suspicious features of ultrasound or other clinical suspicious features. suspicious cytology or erythroid cell is treated like malignant tumor. So our first scenario is a patient with suspicious ultrasound or clinical features who undergoes FNA and it's reported as benign. What is the next step in this situation? The management is follow-up. It could be achieved by annual ultrasound or by FNA every 6 months. Also remember, if these patients have enlarging nodule, the FNA should be repeated. The second scenario is when FNA is reported as non-diagnostic. What's the next step? Logically, FNA should be repeated. So again, please remember these two very important indications of repeating FNA. One is a benign nodule that starts enlarging, or when the FNA report is non-diagnostic. So in this situation, if the non-diagnostic remains non-diagnostic, it means we haven't found any suspicious follicular or malignant features. We can continue with follow-up similar to benign tumor. So what are the indications of follow-up after FNA? If for one report we have benign, or for 2 consecutive repeated FNA we have non-diagnostic report, we can follow up. Next scenario is FNA reports follicular cytology. Why this is a challenge that requires further workup? It's a challenge because follicular carcinoma before invasion of the thyroid capsule or vascular invasion presents as well-differentiated uniform cells similar to follicular adenoma. In other words, absence of capsular or vascular invasion is not enough to claim a follicular cytology is benign. Please remember this. Of course, if there is vascular invasion or capsular invasion, we treat it as thyroid cancer with surgery. But report of follicular cytology requires assessment either by molecular testing or by radioactive iodine scan to rule out or rule in malignancy. Now, equivalent to follicular cytology in FNA are these things called AUS and FLUS, atypia of undetermined significance or follicular lesions of undetermined significance. We treat them same way that we treat follicular cytology, with either molecular testing or radioactive iodine scan. Be careful not to interpret atypia as malignancy. If atypia or atypical cells in cytology are of undetermined significance, it's not necessarily a malignant report. Finally, we have either malignant report or suspicious cytology or Hürthle cells. By the way, do you remember where else we heard of Hürthle cells? Hürthle cells are the pathologic feature of Hashimoto's thyroiditis. But unfortunately, Hürthle cells are also associated with certain types of thyroid cancer. The most famous of them is the Hürthle cell carcinoma. Not one of the most common types, but again, if we have a thyroid nodule with suspicious features and FNA has reported presence of Hürthle cell, we manage it similar to the management of malignant tumor. By the way, if it is Hashimoto, what other findings do you expect to see? We expect to see lymphocytic infiltrate in the biopsy in addition to presence of Hürthle cells. And the thyroid does not necessarily show a single nodule. It's either uniformly enlarged or has multinodular texture and appearance, or one lobe is significantly larger than the other lobe. Also, the serology would show antithyroid peroxidase or antithyroglobulin antibodies. How do we manage this FNA report? With surgery. Also, based on what we studied so far, what is the major limitation of FNA in assessment of thyroid nodule? FNA can differentiate between benign and malignant thyroid lesions with the exception of the follicular pathology. Follicular pathology, especially if evidence of capsular or vascular invasion is not present, requires further workup to differentiate between benign adenoma and follicular carcinoma. Let me add to this. True or false, we generally don't use radionuclide or radioactive iodine uptake scan to differentiate between benign versus malignant thyroid nodule. That is true. Is there any exception to this? Yes, when a nodule is high risk and FNA results comes back as follicular or ATP of undetermined significance, radioactive iodine can help differentiate between benign or malignant. Otherwise, what was the major indication for use of I-123 scan? Assessment of hyperfunctioning nodule. That's a nodule with low TSH. Now, my final question of this episode is, in deciding between molecular testing versus I-123 scan in the workup of follicular cytology, how do we choose between these two? Remember that at the beginning we mentioned several high-risk or suspicious features for thyroid nodule, and we also said if any of them are present, we need to perform FNA. Based on this, please remember that it is possible that a thyroid nodule has high-risk features such as the size greater than 1 centimeter, irregular border or echogenicities in ultrasound, but still have low TSH. Low TSH alone is not enough to claim a nodule is low risk or benign. It needs to be low TSH and no high risk or suspicious features. We follow the same logic here. We say if a follicular cytology is seen to be found in a thyroid nodule with low TSH, in that condition, only in that condition, we use I-123. So even though I mentioned that these are the two uses or indications of I-123, still it's the same. It's a follicular cytology if we have low TSH. In other words, the main test of follicular cytology workup is molecular testing. Now, remember, molecular testing may not be available, but if the patient's TSH is not low and molecular testing is not available, what's the next step? The next step is diagnostic surgery. Likewise, if molecular testing shows evidence of malignancy, the next step will be surgery. Same ways, if iodine 1, 2, and 3 scan shows non-functional nodule, the next step is surgery. Now, you may wonder, is it possible that a low TSH condition be associated with non-functional nodule? Yes. The rest of the thyroid may be hyperfunctioning, but that specific nodule is cold and non-functional, which is a suspicious or high-risk feature. Remember, TSH does not evaluate the function of the nodule. TSH tells us the function of the entire thyroid gland. We could have hypofunctioning thyroid with one single hyperfunctioning nodule. We could have hyperfunctioning thyroid with suppressed TSH but a cold nodule. That is why nodule assessment requires radioactive iodine, and it can be totally different and opposite of the TSH results. I hope this helped untangle some of the confusions associated with this approach. And this is our approach to thyroid nodule.